logosomics can do, not only with identifying subtypes, but it can also begin to identify what's going on underneath those subtypes. So if we have an acute onset subtype, a post-viral subtype, we can begin to identify the pathways, the disease pathways that are involved in that subtype. That also gets us to additional types of treatment approaches. Again, if we begin to sort out this very mixed population into subtypes, we can then begin to target specific areas. And it's all because of big data.
Couldn't the value
Because
to
for so long, there wasn't a subtypes, and so nothing could get approved even if it helped you.
That's right. And subtypes
I
are
haven't
huge,
been through that.
hugely important for clinical trials. Hugely important.
couldn't this be a
That's
multi-million-dollar company?
Oh boy, man, she wants me to retire, doesn't she? I hope so now. We do realize that there's huge potential value in this platform, yes. Because it is designed,
Do you accept investors?
it is designed,
Yes.
it is designed to get at the root cause. The way, I mean, the guy that designed this is a physicist. And so he has designed this to get at the root cause. So it is a causal machine.
Can I ask, is that drugs that your combination that you're coming out with, is it just for people with CFS? Or is it any type of subgroup of CFS?
So the indication will be ME CFS. And that will be part of the conversation that we have with the FDA.
So it won't be including any subgroup then?
Well, the first trial is a small proof of concept trial, so it's only going to be 20 patients, and that's only to be able to generate the evidence that we need to take it to the next phase. So with those 20 patients, we will try to stack the deck in our favor to make sure that we pick the types of patients that will be responders.
Okay, but is that just the CFS patients?
Yes. It'll be a very specific
Very
ME
narrow
Yes.
window.
Yes, for the proof of concept, because we have to make it work, right? This is an example of how logosomics is already working. Again, this is using data that was generated from the survey that we administered that had the 20 some odd FDA questions that the FDA posed. And we administered this survey out to the world, so some of you may have taken it, and it was a horrible survey because it was a question and then you were allowed to write as much as you wanted. Okay, I don't know if any of you took it, but we made it so that you could just write. Okay, so we wouldn't bias any of the responses. Of course, the problem with that is it was an analytical nightmare. You know, no longer are you just analyzing yes, no. Now we had about 1 million words of unstructured text. So what logosomics can do, again, thinking that it takes unstructured, crazy language stuff, translates it into a common language, and in this case it puts it into a medical language. It takes very colloquial, common speak and puts it into a medical context. And when we did that, what it was able to do was to identify a number of different subtypes, just from what you are saying, just from how you responded to questions. I mean, this is mind-boggling. And so what it did was it identified immune subtypes. Again, probably not a surprise to any of you guys, because you guys live this stuff. A pain subtype, a cognitive subtype. Each one of these was a very specific type of group subtype. So you can imagine that each one of these could be targeted, could be understood at a biological level in a much different way than before. And you also see that there's not just 3 subtypes. There's not just 6 subtypes. This is 35 subtypes.
See, pain is your biggest one, and with the way they're treating pain patients at this point, a lot of the drugs that would normally be considered useful for pain medication, they're trying to stigmatize already. I mean, as you go to a pain clinic, most of them want to just give you injections. They don't want to utilize any of the other medications. They're trying to put commercials on TV about how certain types of.
I want to give her a chance to sort of wrap up here, but go ahead if you want to answer her question.
Yeah, I don't have an answer, although I was surprised, again, just from my anecdotal living with, you know, in the CFIDS Association and among the patient community now for the past 5 years, I was surprised at how much pain came out from these survey responses. I was very surprised because we hear that, you know, pain's not an issue. It's the exhaustion that's the issue. But it was very interesting at the FDA meeting when there were patients talking, when they posed the same questions that we posed. It was how they described what then becomes categorized as pain. It might not be, you know, it's an ache in my joint. It might be the pain of walking up 3 steps, or, you know, the pain of that I feel because I can't breathe right.
How about you just feel something?
That's a really good point.
I mean, it's the interpretation. And this is, I mean, much to the FDA's credit, this is what they said has been wrong with not only with ME CFS, but with a lot of diseases. We don't understand what is important to the patient. So a standard instrument on pain, like you were saying, doesn't get at the kind of pain that is the ME CFS pain.
Or even just the way they're stigmatizing any of the medications that are used for pain.
Yeah, but yeah, I don't know about that, but I think this is just an interesting way to capture the patient's voice in a way that hasn't been captured before. To use what you're saying and describing in a way that hasn't been done before. And so, in summary, here's where we're at. We have created a participatory, predictive, personalized platform by creating the biobank, by collecting the types of big data that we collect on our crowd, you. We use this information to identify predictive markers. They can be genetic markers. They can be subtypes and understanding the specific underpinnings of those subtypes. This allows us to be able to, our resources here allow us to be able to reproduce and validate these findings, which again, who was talking about the light study? You know, that hasn't been done, right? Mm-hmm. So we have created an infrastructure that we allow the type of reproduction and validation that is required in order to get something into treatment. Ultimately, this is where we'll be at. Not, you know, a blanket treatment for everybody, but an N=1 type of characterization for ME CFS. And this is the personalized method.
Because it's not one illness, it's a syndrome.
Right? And as I showed you in that last picture, it's at least 35, probably even more. Probably what we'll get it down to is hopefully an N=1, and be able to understand how to deal with an individual patient. None of this could be done without you. None of this can be done without the partnerships that we have formed and are beginning to form and will continue to form to make this possible. And some of these are listed here. So most of these are ME CFS organizations that have signed on and said, you know, we're on this. We're going to be part of this effort. And again, patients like me, very interested. The ME CFS community is one of the largest communities in the 200,000 strong patient community of patients like me. So that partnership brings a lot of cachet to our community, that partnership with patients like me, as well as a large patient community. So Mark, you talked about...
You know, we'll just move on and take questions. I've always said that Suzanne is the steak and the sizzle. I'm just the sauce. Some people don't even like sauce with their steak. So, anyway, you know, if we can take questions for as long as we can take questions.
Well, let me ask the group here how, you know, you're welcome to go. You know, if you're tired or you're beat, Suzanne and Mark have been generous enough to stick around. We have you until 4:30, so I'm going to probably stay for a bit here. But how many people want to stick around for a little bit longer? Want to hear some more? Okay, good. Then we'll do that, and then maybe around 4:20 or so, I'll stand up and call a halt and everything. So anyhow, if you could take some questions, that would be marvelous. This was a great. This gives one of the. It's really hopeful to hear the kind of things. Sometimes we feel we're not a big group like the Massachusetts group. We're kind of far away from North Carolina, so we don't really feel the urgency. We don't see all the breakthroughs. We can read about them, but to hear you talk about them in person is very gratifying. So,
Well, and we are going to do a much better job at communicating, at engaging than we have. Because we have to if we want to get anywhere.
let me ask you a sort of an activist question. Maybe you can give us some advice. Recently, there's been, you know, Ampligen goes before the FDA a couple different times, and every time there's a big blast, send letters to FDA, send emails, and we do it. You know, we participate. And then there was another thing. There was recently stakeholders kind of a meeting for the first time.
That was the FDA.
FDA. That was another thing where they encouraged you to participate. Send your email, send a text or something. Do you think these things are helpful? Sometimes we kind of wonder if they're going to get just kind of thrown off. I mean, we're not the HIV/AIDS community. We're not marching on Washington. So, what can we do? What would you suggest that we do to put pressure on these people to get them to do more for us?
Well, I think, Mark, you need to come up here with me. Because Mark was instrumental in bringing on a person, her name is Lee Reynolds, and Lee is our engagement and communication person. Lee is going to be the representative on the CFS Advisory Committee for the CFIDS Association. Lee is an expert in communication, particularly when it comes to the patient voice. And her observation after going to the advisory committee meeting in May was that we definitely have a cause, and it's a powerful one, but we have a population that is like singing all out of tune. Nobody's saying the same thing. Nobody wants the same thing. Nobody has a unified voice. And so, as an organization, we hope to be able to help our community have a strong and unified voice, which will be much more effective than, you know, email blasts that may not be coming with the right voice.
Yeah, literally, I've got a slide on a thing about these partnerships that talk about you know, the passion of one, the power of many, or the power. Yeah. Anyway, something to that effect. We're much too small of a disease state to be as fractured as we are. Whether it's geographic fracturing or whether it's ideological, you know, I mean, some people want to say, Ampligen, we need to storm Washington.
Right.
And then all the people who aren't with us, well, they must be against us, which is not so. It's that each of our uniquenesses come out in various ways. Consequently, we're working to be that really umbrella for a federation of organizations just like this one, so that we multiply your voice many times over, and yet we're all working down the same path together. And let me tell you, it does matter. Again, I can draw from a lot of years at the Polycystic Kidney Disease Foundation. One thing we were very good at is government advocacy. And we got, because PKD is a genetic disease, we got the Genetic Non-Discrimination Act. We got it passed after a lot of years. And so effective was our little organization that we got 15,000 responders, which made a difference, versus the National Kidney Foundation's 3,000. And they were 12 times bigger than we are. So it does matter. It does make a difference. Sometimes you think you write letters, et cetera, and it just goes into a black hole, and they'll go into file 13 in some Washington thing. Something in
I
Washington.
can't tell you how many years on CFIDS Awareness Day I asked the support group members to write to their congressman, or write to this person, or write to that person. And we've been writing for a lot of years now, and it kind of feels like wasted energy. So any way you could harness that would be.
Yeah, how many have ever advocated on Capitol Hill?
You mean in Sacramento, because we're not getting out to
Yeah, exactly.
Washington.
Well, when you do, you go and you talk to people who are probably your kids' age.
staffers.
Staffers.
The very best thing to do is on Monday or Friday, because your congressman is usually home, to go visit him. Because he's here. His staffers aren't. And you are a voter. And that carries a huge amount of weight, especially closer to election time.
But one of the things that we're going to do
Depends.
is really begin to provide
We're
those
gonna
types
help.
of templates and tools.
Tools.
Those
yes.
types of guidances to help all of the independent organizations, again, function more efficiently and with a unified voice and approach that becomes much more powerful. It's power in numbers.
Right.
Well, that leads me to ask you, I think you sound very optimistic today. Do you think the FDA, to pick one body, is more, do they believe in the illness more today than they used to? Are they more interested in the illness? Are they more afraid of the patient
Is
population?
Sibelius more open to us?
So let me address Mike's point first. So the FDA has a federal requirement called PDUFA. It's the Prescription Drug User Fee Act. And part of PDUFA was to organize a series of workshops for at least 20 diseases that represent serious unmet medical needs. So they picked 20, and we were the first. ME CFS was the first of 20 to go up. What that meeting was not only hugely important, I mean, it was the much coveted slot. There was how many diseases were up for this, like 200 or so,
Oh, yeah.
if not more. So,
These are all smaller illnesses that are not really treated.
heck no. There was, Parkinson's, there was a lot of genetic diseases, there was MS, there was HIV, a lot of them went for this. But ME/CFS represents severe unmet medical need, and it has received the label from the FDA as a serious illness. Okay, so it fit perfectly in their regulatory requirement to address this particular population. So in my conversations with the FDA, they have said, we are here to help you move the ball forward. We will hold your hand to get things forward.
They've said those exact things. As a matter of fact, we weren't, to reiterate, we weren't just one of the 20, we were the first.
So that mattered, that spot
That's
mattered.
huge.
That matters.
That's huge. We
And
had
it
people.
wouldn't have happened had it not been for the patient voice. I'll bet you.
Yes. So that stakeholder effort was hugely important.
Well, that's good. I mean, that means that a certain amount of the letter writing and emailing made
Had
a
an effect.
difference. Then.
Definitely had an effect. Even the Ampligen, the backlash from the Ampligen had an effect.
Because that came out right after Ampligen. was
That's right.
approved.
That's right.
Do you think it will ever be approved?
They got to do the study.
Yeah, to tell you, and again, I'm operating as kind of an insider and an outsider here. I've seen Suzanne, and our president, they're for Ampligen. The organization that has it is just not doing the right process. You know, you gotta do step 1 and step 2 and step 3 in order to get to